Good morning, good afternoon, or good evening, wherever you are. Welcome to today's guest lecture by Jean-Philbert Nsengimana on key policy challenges for eHealth in Africa. We are very privileged to have a speaker who has both the experience of policy making and of managing projects at the intersection of information and communication technologies, ICTs, and healthcare. Mr. Nsengimana is a managing director for Africa the Commons project, which works to realize the potential of technology and data for the common good. He has previously served as the Minister of Information and Communication Technology and Youth in the government of Rwanda. He also serves on many different boards, including the Alliance for Affordable Internet, IntraHealth International, Place Fund, I4 Policy, Startup Genome, and Future State. He holds a Master's of Public Administration from the Harvard Kennedy School of Government, a Global MBA in Information Technology, a Master's in Software Engineering, and Bachelor's degree in Computer Science. So my very welcome to you, Mr. Jean-Philbert Nsengimana. Before we hear from you, a few more words from me. I just want to add that this event is hosted by the Department of Health Policy at the LSE. I would like to thank everyone involved for making this event happen. Of course, my warmest thanks are to the speaker, but also to Aurora Iradukunda and Lucy Thompson for organizing this. My name is Ela Kletsun, and I'm an assistant professor in the Department of Management at the LSE, Information Systems and Innovation Group. I will chair this event. The event will run for 1.5 hours. There will be a Q&A session at the end and an opportunity to ask questions during a pause in the middle of the talk. Please use raise hand feature to indicate that you have a question, and I will do my best to accommodate you. Don't forget to lower your hand once you've asked the question. You can also post questions in the chat box. Time allowing, I will ask them on your behalf. I'm very excited to be here. I've been studying eHealth for over 20 years, but mostly in the UK. But what's eHealth? In a nutshell, these are services utilizing information and communication technologies to deliver and manage healthcare. Proponents of eHealth suggest that it will lead to better quality healthcare, more equitable access, and more efficient healthcare. Today, whilst COVID-19 pandemic is raging on, ICTs are seen as a savior, facilitating the delivery of healthcare at a distance. However, eHealth initiatives I studied in the UK, whilst delivering many benefits, often faced complex socio-technical challenges for many reasons, including the complexity of healthcare practices, heterogeneity of the different stakeholders and their interests, as well as heterogeneity of different technological systems, which were hard to integrate. Often the social and the technical interact in unexpected ways. Over the years, different policies in the UK tried to address those challenges and facilitate an environment in which eHealth could flourish and deliver the benefits we were promised. Many different countries, be it in high-income countries or middle and lower-income countries, share those challenges. But equally, each country faces unique challenges as well as opportunities. We can all learn from each other's experiences. And today, we are here to learn about eHealth in Africa. So without any further delay, let me invite Mr. Nsengimana to start the presentation now. Over to you. Thank you.
Thank you so much, Dr. Ela Kletsun, for the invitation to deliver this guest lecture. and for the warm words of introduction. I'd like to thank also Aurora Iradukunda and Lucy Thompson for your precious support preparing for this event. I greet and welcome all participants from joining us from LSE and across the world. In particular, I'd like to greet those who are with us from different African countries, and especially from Rwanda, where I know that many are with us today. Can you see the next slide, please? Cool. I was muted. I hope you could hear my opening.
Yes.
All right. So this picture is of Francoise Nsengimana, a young lady with her 8-month-old baby, Bertrand. It was taken in front of her home in Muhanga district, southern province of Rwanda. Francoise was the first mother to receive blood delivered by drone at Kabgayi Hospital in the same district. After childbirth, Francoise was dangerously hemorrhaging and needed urgent blood transfusion. Normally, it would have taken 2 hours to order and get blood from Rwanda's then centralized blood bank, and it would have certainly and unfortunately been too late. But a year before, Rwanda had started blood delivery using drones, and the nurses were able to put a request by phone and they get the blood packet dropped in front of the hospital within 15 minutes. Francoise's story reminds me of my own mother's story, which is also my story. I was born in the mid-70s in a rural hospital called Kirinda in the Rwanda's western province. When my mom started having labor pains around midday, she immediately got walking, trekking mountains and crossing rivers. A journey that would normally take hours took her 5. By the time she arrived at the hospital, I was almost there. Fortunately, the delivery went well and there were no major complications. But I always wonder what would have happened if she found herself in Francoise's situation. One thing is certain, I wouldn't be here talking to you today. So why am I telling you this story? I'm saying this to say simply that making eHealth work save lives, as Dr. Cresson introducing the lecture said. Africa still loses more than 530 mothers per 100,000 live births to largely preventable causes. That is hundreds of thousands of lives lost every year, mothers giving life. And the average doesn't tell the whole story, of course, because within Africa, there are very vast differences. In South Sudan, for instance, or Chad, the rate is above 1,100 deaths, while in Namibia, for example, the rate is below 200. Now, compare that with 19 in the US, 7 in the UK, 2 in Norway, you realize that there is a long way to go for Africa, even though the last 20 years have brought unquestionable progress. Postpartum hemorrhage alone is responsible for about 30% of all maternal deaths. So the other way I read the topic today is really how do we make effective use of technology to save lives in Africa? Next. So our conversation this morning is divided into 3 main parts. I'd like to spend the first couple of minutes talking about 3 lenses that will allow us to uncover eHealth challenges. But as many of you suggested on social media, we will also be talking about a few opportunities that hide behind those challenges. The second part will be about what I call the 10 T of digital health transformation in Africa. And finally, we will open it up for questions, comments, no short speeches, please. Before we get started, I ran a poll recently to see what people think about the digital health challenges. I'd like to ask, Lucy to put. So this is the poll that many of you could have seen on LinkedIn and Twitter. So please take a moment, choose what you believe is the biggest challenge, and then we will see and compare with what the public thinks. So the top challenges that I propose here is infrastructure and connectivity, education or talent or capacity, leadership, regulation, and everything that has to do with the role of government, and then financing and investment. So pick a moment, choose what you really believe at the start of this lecture, the biggest challenge to the development of eHealth, and then we shall recap towards the end of this lecture. I'll give you a moment to do that. So Lucy, when it's done, can you display quickly the results? All right, so here is the results. Wow, there is a tie between connectivity and leadership. I like this because myself, I don't know which one to decide, but definitely those are very, very strong ones. We'll compare with what others think. Education, surprisingly, from an education institution is getting the list. I thought everybody was going to say, hey, it's education and we are fixing it here. But it's interesting, and then financing, as you can all see. So thank you so much for participating in this. I should take perhaps a screenshot, but somebody would do it. So in the second part, we are going to go through the 10 T's of digital transformation. It's really a very rough way, a mnemonic device to present otherwise a very complicated reality. So I take 10 challenges with keywords ending in T's: connect, educate, innovate, coordinate, invest, promote, regulate, protect, and trust, and then quit. Next. So let's go on the first lens. Right. So let's go on the first lens. The first thing I would like to do is to establish a common vocabulary. And I'm happy that Dr. Cleston has already done a bit of that already, so I won't repeat what you said, defining eHealth, but I'd like to sort of present this breakdown, which presents eHealth in 7 major buckets: leadership and governance, infrastructure, investment and strategy, standards and interoperability, services and application, legislation compliance, and workforce. So the leadership bucket is mainly concerned with directing and coordinating eHealth at national level and ensuring that eHealth programs are in alignment and support the policy and the political goals of the country. It's about promoting the awareness and engagement of stakeholders, providing the coordination, partnership mobilization, and the adoption of eHealth services and standards. It's also about supporting and empowering the required change and the implementation of different recommendations that are made by the different stakeholders. The infrastructure piece, which is critical, and I will come back to every one of these components, form the foundation of electronic information exchange. You can see it as this hard infrastructure, but also the soft infrastructure or infrastructure, as one of my friends or Lasipo Yadepo likes to call it. So let me jump straight ahead onto the next slide, because I will get back to these components later. The other source of challenges is the unique Africa context. Now, I assume that we all don't have the same understanding and knowledge and background of where Africa is on its journey towards transformation, but I would point out these 5 factors to just keep in mind as we go along. The first one is about the people. So demography, Africa is the youngest continent with a median age of 19.3. But if you go to some countries like Niger or Uganda, you will find that the median age is actually below 15. In Niger, it's 14 years. So half of the population being of the age of 14 and below. The next important element is about the talent, especially the healthcare workforce. 0.23 physicians per 1,000 people. I'll get back to this. This is really one of the biggest.
My apologies. I just lost power. I forgot to connect my laptop. I will be back. Right now, I'm using my phone as a backup. Give me 1 second to reconnect on the laptop. But I can talk through this slide if you can hear me. Okay, thanks Adele for the thumbs up. So the talent side, and then the infrastructure. And I divided this infrastructure. Normally connectivity should be part of it, but I think it was important to have digital infrastructure as a special bucket. Now, on the infrastructure side, one thing that is very important to healthcare and eHealth is about power and electricity, and the fact that less than 50% today of people live in places where they have access to the grid. And then I'll also talk about the resources. The headline figure that I have taken is the per capita health spending, $84 per person in Africa per year, while in the US, for instance, we're talking about $10,000 per year per person spent on healthcare. So you can really imagine what this means when we start comparing the health outcomes on the 2 continents. So can we go next? I think I'm about to come back to my laptop. Give me 1 quick second, please. Right, so this is about the talent challenge. There are many mismatches. There are many imbalances and many tensions between supply and demand. And this is just one of them. And for me, is one of the biggest. I mean, we will note that there are such tensions on supply and demand of infrastructure, equipment, and everything else. But I think the human factor is a challenge. So the headline here is Africa will be running a deficit of 6 million health workers by 2030. So everybody here is a shout out to everybody who's doing something about this challenge, training doctors, nurses, community health workers, and other healthcare professionals. They are really contributing to a cause that is very crucial to the improvement of healthcare on the continent. Next. I'm still struggling a bit to get back on my laptop. I'll be here in a second. So let's talk through the third bucket of challenges. The source of challenge that I have picked is also about policy making itself. So policy making is a difficult exercise. People like to see it as one thing, you know, an exercise to design and launch policy, but I look at the 5 steps from the policy, the problem identification, to design, to the adoption, implementation, and evaluation of policies. So you realize that when you start working through this cycle, the cycle can break at any point. Challenges can come up at any point in this cycle. So as we go through the challenges, think about what could be the problems at every step. So at problem identification, for example. Okay, I think I'm back. Let me leave this one.
Well, these are the challenges of digital technologies. Although it helps to link us up, we still sometimes struggle to utilize it. So let's hope we can reconvene in a second.
Oh, I'm here. Can you hear me?
Yes, thank you.
I'm sorry for the interruption. I'm back. Thank you so much for your patience. I was talking actually initially muted through this slide, saying that the Pareto principle applies on this slide in terms of where most of the challenges appear. And I was saying, and subject to discussion, I'd like to hear from you at the end, that implementation takes up 80% of all challenges. Problems rarely have to do with bad strategy or absence of strategy. It has everything to do with implementation. In fact, I was asking WHO Afro, and I learned that 42% of countries have a national eHealth strategy in Africa, that out of 54, and that is 77% of all countries in Africa that have a national strategy. So we can actually not say that the problems that we've seen in the eHealth development reflect a lack of strategy. I would say it's more about how the strategies are implemented. Next. So let's dive straight into the 10 tips. But before we go there, I'd like to make a pause and see whether there are any quick reactions, quick questions. I've seen some chats. I don't know, Dr. Cresson is monitoring the chat. If there are anything that I should talk about, please let me know.
We have one question. So perhaps, Gungur Jean-Claude, would you like to ask this?
Hello, everyone. I just want to ask the presenter about this question. Maybe at the end, I just post it so that maybe he can reflect about it at the end of his presentation. Thank you.
So, by the way, the question was about the challenges related to the implementation stage of the cycle. Yes. But perhaps that's what you will be discussing.
Exactly. Good.
Yeah, I'll talk about it, but quickly, as I said, there could be challenges at any phase. You know, look at the 5 arrows. There could be challenges at any box, any arrow. I said many problems rise at the implementation because of, for example, think about the amount of coordination that is required for an implementation of an eHealth program or initiative or strategy to happen, the different stakeholders. So think about the resources, think about the lack of skills and competence, the lack of capacity, both human and institutional, everything that, you know, comes to impede the successful implementation of an eHealth strategy. And yeah, so those are some of the few things I can say, but we will get back to each of them one by one. So let's now dive into the infrastructure. This Connect challenge is really about infrastructure. And when we talk about the hard infrastructure or physical infrastructure, roads come to mind, aviation, water, sanitation, urbanization with some of the metrics that you can see, the healthcare facilities and equipment, the buildings. Think about the distance that people need to travel either by walk or by driving to reach the nearest health facility, and also digital. So let me comment a little bit on the roads. For example, Africa has about 1.75 million kilometers of roads, and most of these roads were built primarily for the colonial exploitation of minerals and agricultural resources. The network is really still insufficient, inadequate, and not well maintained in many places. Same goes with the continent's 260 international airports. So in this COVID-19 context, for example, even assuming that the massive vaccine inequities and vaccine nationalism problems are solved, we can say that delivering vaccine to the 1.2 billion people on the continent may lag a few years behind the curve just because of that infrastructure problem. Vaccination needs a different type of infrastructure. It needs cold chain. Today, 48% of households have access to electricity. We can say that's roughly the same about health facilities which can store the vaccines. So in this context, for instance, how do you think about building a cold chain that is going to serve the 640 million of people who live off-grid? So the conclusion on this one is powering Africa or lighting Africa is really saving lives. The problem with hard infrastructure, buildings, roads, electricity, is that they are capital intensive. They take a long time to build. They take time and money. And you may argue that Africa has the same amount of time as everybody else. But I can say that when we still lose disproportionately more lives to preventable causes, and at a time where some of the technologies and the resources are available to prevent those, I think Africa policy makers need to feel the ticking of the time even more acutely than everybody else. Time is of essence in this case. And I think this is where really the innovation idea comes to mind, doing more with less and turning challenges into opportunities, and also the opportunity to leapfrog, and as opposed to a mindset of improving incrementally. For electricity, for example, the use of solar power comes to mind. Today, solar power can be cheaper and greener than any other source of power that you can think of. For roads, using drones has become a new possibility that could not even be dreamed about a few years ago, or even in some places today. So I'd like to jump on the drone use case to illustrate how Africa could be leapfrogging some of the infrastructure problems. Next. So this picture shows a drone that is dropping a packet of blood. The company is called Zipline, and I had the benefit of being in office as minister when this initiative started in Rwanda. The problem we had at that time, and I would say it's just the tip of the iceberg of the problem, was how to save lives of people who needed urgent blood transfusion or blood products that cannot be stocked effectively in every hospital. In that emergency situation, even a minute can be the difference between life and death. And while most hospitals could stock the most used products, and including blood products, there is not enough supply of stock for some rare blood groups, for instance, or even the infrastructure to store some products like frozen plasma and platelets. But the iceberg itself is the entire medical logistics supply chain. So think about routine products such as vaccines. So Rwanda is relatively a small country, but with well-maintained transport infrastructure. However, it would take an average of 2 to 4 hours for a round trip from a rural hospital to the capital city to get the supply of an emergency product. With Zipline, that time has been reduced to about 15 minutes from the 2 operational centers that the company has set up in the country, which are able to provide the full coverage of the whole country. But despite the clear benefits of technology and the political support that we had in Rwanda, launching the operation was faced with many challenges. First, there was no regulation on how commercial aircraft can share the airspace with drones. When the partnership started in 2016, we only had regulation for remote controlled line of sight drones. And Rwanda was quite among the few countries that even had those regulations. But Zipline brought a new drone technology, which was completely autonomous and beyond visual line of sight. There was no precedent to learn from. A lot of policy innovation and regulatory flexibility was required, but all had to be done in ways that don't put in any way possible the security and safety of Rwanda's airspace at risk, because the country had a lot more to lose in case of problem. As a landlocked country, Rwanda could not afford to have its airspace blacklisted or downgraded security-wise by the International Civil Aviation Authority. Rwanda used to be a landlocked country, but now thanks to digital innovation, such as drones and broadband connectivity, the country is no longer landlocked. It is now land-linked. There was also the risk of failure that comes with being the first at embracing any new technology. No one wants to be the first to fail, but Rwanda took a deliberate decision to accept that risk. In fact, the country has announced its willingness to be a proof of concept nation for new generation innovations that have global and broader Pan-African relevance and application. And this is also where politics comes to play. The risks and rewards in politics and business are distributed differently. In both domains, risks are always personal. But while the reward in business is personal, in politics or public sector, the reward is public interest. It is distributed. So some people who do politics for personal interest will be enemies of innovation, but that is bad politics. But this explains, at least in part, why innovation in government is slower than in private sector. The reward for taking the risk is the opportunity to leapfrog, solve a problem at hand, but also create an industry in the process. Today, Rwanda's drone industry is thriving as a result of the success of Zipline. The regulatory and business environment that were accelerated during that first initiative is now serving so many drone companies in domains such as precision agriculture, environmental monitoring, urban planning, media production, and so forth, and so on and so forth. And really, my preferred benefit is to see these young people who got, these future-proof jobs working in Rwanda, but also working globally as the company keeps growing. Next. So this picture shows the launch of the first drone in Rwanda by His Excellency President Paul Kagame on October 16, 2016. Without the president's personal leadership, I can attest that the project, which took 6 months from inception to launch, would have either never happened, never seen the light of the day, or would have taken 2, 3, or 5 years even to materialize. The rest is history. Next. So from Rwanda, Zipline now operates in Ghana, where it was able to beat the rollout expectations to connect more than 2,000 hospitals across the country. In Rwanda itself, from 12 hospitals in 2016, today the company is serving more than 400 centers, and there are discussions about even doing home delivery. In fact, during this COVID period, there are patients who were on chemotherapy who could not have their supply, prescriptions, and drones were used to drop them at the nearest health facilities. Next. So the second group of challenges will and opportunities have to do with digital infrastructure and systems. You can call that infrastructure. Within the infrastructure, there are many components such as computers, cloud, fiber optic networks of all sizes and shapes. But I have decided just to focus on one, which is mobile technology. Mobile is the first technology that spread the fastest on the continent, defeating analyst expectations and predictions that the industry would fail in Africa due to low incomes, electricity, which made business case for telecoms not viable. But it happened, and for the first time, millions of Africans got a lifeline. They got a voice, they got a channel to access information and a chance to be included financially and otherwise. 15 years ago, I got a job to serve as the country director for a mobile health company called Voxiva in Rwanda. At that time, less than 5% of Rwandans had mobile phones. Internet penetration was about less than 1%. However, the immediate value and potential for future impact was clear. at a time when the country was working to scale up the HIV/AIDS program at national level to ensure that everyone has access to test services, that everyone who tested positive starts treatment, that every transmission from mother to child is prevented, the ability to have accurate and timely information for decision making was vital. So data managers were hired in every health center and were equipped with a simple mobile phone. On a monthly basis, they used to report through interactive voice response or text the performance of the program on 42 critical indicators, ranging from new patients that tested positive to those who were lost to follow-up. The platform also generated alerts for risk of stockouts for HIV drugs, which were a key input for streamlining the drug logistics. Rwanda went on to become one of the most effective countries in combating HIV/AIDS in the decade that led to the end of the Millennium Development Goals era. Today, the mobile penetration in the country has surpassed 80%. Internet access is more than 50%. So you can understand that the possibilities to leverage that infrastructure for improving healthcare outcomes has increased exponentially. Around the continent, there are more than 800 million SIM connections. That is about 500 million unique subscribers. So 45% of the African population is connected to at least simple mobile services. 44% have mobile phones. Only 26% have access to internet, and 9% 4G connections, which represent internet broadband for mobile phones. So the job to connect the continent is still one of the biggest challenges. Next. I'd like to talk about another favorite company of mine that I saw taking the shape, which is called Babel. In fact, the name is Babylon Health. It's headquartered in the UK, but in Rwanda, it's called Babel Rwanda. And I was speaking to the CEO 2 days ago, Dr. Ali Parsa, my friend, and he told me that really the challenge that got him started is how can we leverage technology to try and solve this triple tension, the tension between the cost, the quality, and the access to healthcare services. Next. In addition to the three, there is also the complexity of care. When you think about the care, the healthcare user journey or user experience, starting at the village level, going to the health centers, going to, in case of referral, to the provincial hospital or district hospital, and then up to the referral hospitals. It's a painful journey if somebody has to start right at the bottom to reach the top. It could take months, during which the condition of the patient could be worsening. But with Babel, here is the user journey. If you go next. So here is the user journey. A patient is able to book an appointment using an USSD application, just dialing 811. And then a triage nurse will call the patient back in 5 minutes, within 5 minutes. And then if suitable for digital health, an appointment is booked with a GP, or a prescription is generated for lab, exam, or pharmacy collection of medication, and it's sent by SMS to be redeemed at more than 500 facilities. So Dr. Ali was telling me that, in fact, the quality of care, in this case in Rwanda, is higher than in the US or UK where the company operates. And because it's just not possible to get a GP appointment in the US just within 7 minutes, but it's possible in Rwanda. So the other really interesting aspect of this company is the use of artificial intelligence. The whole triage and screening, what the nurse has to do is just to input the symptoms, and the AI engine can help generate options for diagnostic. And this is learning and improving by the day. So when I asked him about the challenges, he told me that definitely financial sustainability for the business in Rwanda is a problem, because they charge 50 cents per consultation, while they are able to charge 50 times more in UK and US. So for the business to break even in Rwanda or low-income countries, the volume needs to cover for the very low margins. And he was telling me that that is not yet possible because they are not able to access everybody. They are allowed to only treat people age 16 and above. And they were saying that they are really looking forward to the time where they can extend the benefits of this technology to the entire population, which will contribute to improving the business case. And this is also something that I'd like to call out as a broader challenge in Africa. You can ask yourself, if such a low-cost business case cannot work, how does the medical service generally work and sustain in the country? And the answer is there is a lot of subsidies that go into meeting a lot of healthcare costs by the government. The fact that more than 80% of primary healthcare is done using government facilities in the country, which government has paid for the construction, pays for utilities, pays for the workforce, and all of that is not available to a private operator. So if you really want to do the healthcare business at the bottom of the pyramid, the business model needs to be revised. And for innovation to take off, healthcare has also been very socialized. The fact that there's all this donor money and social protection benefits that governments put in, if those are not extended to entrepreneurs, they're not available to innovators, it will be difficult. So there is a case here to think really hard about how do you start looking at business of healthcare in Africa as a business, not as a social service. But I'm not advocating for transferring the burden to the patient, but for a better distribution of incentives in the ecosystem. Next. So, Bubble, to conclude on this case, it has grown. Now 2.5 million of registered users, 1,600,000 medical consultation completed, around 3,500 consultations a day. Ali was telling me that if you put this to the scale of the US, that would represent about 150,000 consultations a day. So that is really a world record. And then 12,000 people trained on digital health in the country. And then really, I think my favorite is the fact that the government accepted to sign a 10-year contract in which every citizen will have a digital health record started and hopefully maintained later and connected to the other health data. So this is really something that is revolutionary. Next. So we've covered the Connect challenge. I spent a lot of time. I will try to run through the other challenges a bit faster. So let's go to the Educate challenge. This is the talent challenge. One way of looking at the challenge is through this map. The map shows the number of inhabitants per doctor. Although it's an old map, but you can still find many of the realities are still relevant. You have in Germany, for instance, you have 350 doctors per 301 doctor for 350 people. That's the UK. Germany is 250, and the champion in this category is Cuba, with a doctor for 118 people. I was really surprised and somehow disappointed that many online sources don't even make a mention of Cuba. It reminded me of the big bias against low-income countries in the international development space. But that's another debate for another day. In Africa, the situation is stark. One doctor for about 4,000 people. And some are doing better than the average. Nigeria, for instance, it's a doctor for 2,600 people. But a lot of other countries have a long way to go. Malawi, for instance, one doctor for 27,700 people. Tanzania, 70,000 people. So the talent challenge, just from the view of doctors, is huge. But it's just an indication of the same problem even on the other levels of the healthcare pyramid. So if you look at the pyramid, next slide. There are three levels. There is the top level of policymakers and innovators, those who can create eHealth solutions. There is the mid-level of the workforce, doctors and nurses. And then there is the bottom, the citizen, where you find the citizen and community health workers. So at the top, the challenge, there are so many challenges, but at the top, the one challenge that I'd like to call out is it's what I call the CIO challenge. The fact that we don't have enough doctors who really understand and love IT, or enough geeks or IT professionals who understand healthcare and are able to mediate between the two important fields, because eHealth happens at the intersection of the two. So the CIOs, those I call the chief information officers, are like translators between the two groups. They don't need to know, computing or programming to be, if they are public health experts, they don't need to know all of that to fit into that category. But in my experience, one thing I realized is that each profession doesn't realize that they speak in jargon that the others have a very hard time to understand. So the main job that CIOs will do is to really translate the needs, the concerns, the frustrations of one side to the other and mediate a solution. In the middle of the pyramid, the biggest challenge there is productivity. How doctors, healthcare professionals can effectively harness IT to be more productive. But I would take the example of data managers, because I've seen this many times where you have a data manager using Excel, but keeping the old calculator very close. Somebody who simply doesn't know how to use a formula into Excel. And you can imagine also the impact on data quality. So the proficiency and the quality of skills at the intermediate level translate directly into productivity. And sometimes one of the biggest problems there is people will not adopt IT fast, because at some point it represents an extra burden. They use IT on one side and they're keeping the old register, the old paper on the other side. And for them, that's the double the burden. And then at the bottom, we have the digital literacy challenge. This is the demand side of the eHealth solutions. No amount of innovation will be successful if the users are not ready. The assumption that everyone who's got a smartphone is empowered to be a digital health consumer is simply wrong. In Rwanda, we started a program called Digital Ambassadors with a strategy to deploy unemployed high school graduates on a mission to train the entire population in basic literacy skills to enable them to use mobile for financial inclusion purposes and accessing, other services like eGov, e-agriculture, but also eHealth. So I think thinking really about digital talent in the different levels is important. So next. Again, on the talent challenge, I'd like to say that I recently joined the board of IntraHealth International, an organization that is dedicated to improving the performance of health workers around the world and the system and strengthen the system the systems in which they work. IntraHealth has extensively researched the question of the future of Africa health workforce under the influence of technology. And they came up with these scenarios that I would like to share with you quickly. So, as you can see, there are three main futures they designed. The first is a cyberpunk Africa. The second is what they call further together. And the third is what is called muddling through. Next. So the cyberpunk Africa is this situation where health data harvesters, and you know what I mean, they get empowered. People are treated as subjects. You can actually press next on this. Yeah, there. So, no, go back. Right, exactly. Your privacy is my profit. So they are formalized gig workers who provide some type support to really collect health data, and patients themselves, they keep sending their data aided by technologies. So this results into amplified capacities with AI assisted tools. There could be a possibility for high quality concierge service for high income patients. The condition for this future scenario to develop is a highly fluid labor market with a gig economy like sorting of workers, lower level of official accountability, but also reliance on patient reviews, and more black box diagnostic and care technologies. So in this scenario, Africa goes into some kind of digital colonization as far as healthcare is concerned. Next. So in the muddling through, first of all, the current condition, the way the power is distributed in the healthcare system and the decision-making authority, if that is shifted from government to insurance schemes, and pharma, for example, which is the situation here in the US, where I'm speaking from. So you will see that the main actors in this situation is the existing tiers of licensed professionals with some formalized community health workers, the providers of credentialed professionals, and then the specialty clinics and healthcare providers. You can expect that in this future, more non-communicable diseases work will continue to be done, but fragmentation will continue. similar care as today, but with more tech tools. There will be more variability in care on the ground, even with the same diagnosis. So countries will declare that they have achieved universal health care, but the numbers will tell the quantity story, but the quality will still be a big problem. Next. And there is the best case scenario, which is the further together. A scenario where you can go next. Next. I'm stuck on the further together scenario. I want to move fast. Next.
Lucy,
they could
move.
Mm-hmm. Go ahead, Ella. On my side, I cannot see the. Okay.
Yeah.
Next. All right. So in this further together scenario, the benefits of technology increase. Technology is increasingly harnessed, but the health work power structure evolved and transformed. And in this scenario, Africa is able to attain a situation of better quality for all, supported by technology. So I think I'm happy to talk about this a little bit later in the conversation. I think this is really a good framework to think through the future of healthcare work under the influence of technology. Next. So number 3, we go to innovate. So since the potential of digital health is no longer a question of debate, I think we need to ask ourselves, why is it that the eHealth innovation landscape is still littered with broken dreams? And before starting the blame game between government, universities, healthcare providers, consumers, we first need to consider the issue of ecosystem maturity. We are trying to move two systems in parallel at the same time, the ICT environment and eHealth enabling environment. And there will be unavoidable challenges based on the stage of maturity. For example, at the very early stage, that is called experimentation stage, when the ICT environment maturity is still low and the eHealth environment is still low, that situation will be characterized by many proof of concepts which are likely to fail, to scale, or to sustain. That stage is also characterized by lack of adequate infrastructure and skills. So failure there is normal, will be part of the learning. And you cannot jump from that stage to the mainstreaming stage, for instance, overnight. It has to be a journey. In the scenario of build-up, which characterizes the fact that the ICT environment will tend to mature a bit faster than the eHealth or the healthcare environment. And then you will get into this build-up scenario where the potential of eHealth impact is broadly recognized, and ICT applications in other sectors, such as banking, e-commerce, eGov, will have picked up. But still, you will see that eHealth will tend to lag behind. So when you see eHealth lagging behind, I think it's important not just complain, to put it into, it's important to put it into this context and realize that it's a normal, part of it can be explained by the normal development process. In that case, the policy making should focus on strengthening the enabling environment for eHealth, put in place legal regulatory certainty and standardization, and start integrating vertical systems. and the mainstreaming, which is the end state. It's the context in which innovation and competition in services is present, with new business models and local as well as international vendors. eHealth is fully integrated into service care delivery models. Paid services and insurance reimbursements are increasing, but most importantly, there is a shift from a provider-led or a public health-led model to a consumer-centric service delivery model. Examples of applications here include like the home health monitoring, chronic disease management, and tailored online services for self-care and health records. So the challenges in this mainstreaming stage will continue to be legacy systems, which will hamper integration effort. In fact, I talked about leapfrogging as an opportunity in Africa, but the window of that opportunity for countries which have reached the mainstreaming stage is closing. Before many countries realize leapfrogging won't be possible because the legacy is already taking root as we speak. So at this stage, policy efforts need to focus on interoperability and standards, incentives for innovation to raise the quality while lowering the cost of care, mobilize medium and long-term financing, and deliver a consumer-centric, user-friendly, efficient, and personalized service. Next. Still on the innovate, here is something that I would really like to share from late Professor Calixtus Juma, which speaks to an important aspect of innovation, which is culture. So here it goes. He says that in the United States, products are safe until proven risky. In France, products are risky until proven safe. In the United Kingdom, products are risky even when proven safe. In India, products are safe even when proven risky. In Canada, products are neither safe nor risky. In Japan, products are either safe or risky. In Brazil, products are both safe and risky. Now, listen carefully, in sub-Saharan Africa, products are risky even if they don't exist. So really, this is a caricature to illustrate how different sociocultural environments respond to innovation and its perceived threats. But the more fundamental challenges that Professor Juma points out are vested interests, which use regulation and intellectual tactics to preserve the status quo that benefits them. So it's hard to defeat enemies of innovation because they are everywhere and they are all powerful. And you don't have to be a bad guy to become an enemy of innovation. Think about yourself. You could find that you are actually an enemy of innovation without knowing. So I encourage you to grab this book and read about some of the epic stories of how almost everything that we take for granted today, from coffee to the printing press to electricity, had to go through an epic journey, delaying progress sometimes for centuries at the hand of extremely smart and well-meaning leaders of government, church, or even academia. Next. In the zipline case, one of the questions from media that came up most frequently was about what is going to happen to jobs of trucks and motorcycle drivers who used to do the delivery. But that question also applies to the companies they worked for. The new technology was clearly an existential threat to them. So my answer usually started with another question. What happened to the typists and secretaries that were here before computers? Well, I know many who went back to school and acquired that dream degree. Others learned to use computers and started cyber cafes, and others are digital content producers. I'm not trying to avoid the big question of the future of jobs and whether that's the big challenge. So yes, it's a big challenge. Should it be left to the market alone to solve? No. Policymakers must help mitigate the impact of creative destruction, which is the process that innovation takes communities and economies through. So how did we solve it? How did we solve for all the policy, regulation, business risks that this initiative presented? The short answer is leadership. Leadership and governance. And this is about the coordinate challenge. So leadership breaks the silos and ensures that communication and collaboration happens across traditionally isolated sectors. For example, the demand that came from the health sector was seen as a risk and extra burden to the civil aviation sector. A new airspace policy had to be developed, and initially, just because of the extra care, every drone takeoff had to be individually authorized as any commercial aircraft. So that resulted into a lot of extra burden that came up almost overnight. But you can also see the other stakeholders had to be brought around the table. So health itself is a collection of so many players: the policymakers, the implementers, the hospitals, and so on. The Rwanda Development Board, which is in charge of promoting investment, was very interested in the possibility that a new industry would create. The infrastructure people had to find a place, utilities, connectivity for the drones to operate from, and so on and so forth. But most importantly, the public. You may wonder, what is the role of the public here? The public played an important role because the public had to internalize and accept the innovation for it to be successful. Next. So I have tried to visualize, and you have the reference there, of the eHealth innovation ecosystem. And you can see here, there are 13 different groups of participants in the ecosystem. So the coordination challenge is big because if you just think about the number of bilateral relationships that can happen between any two of the groups here, those who like combinatorial analysis, you will see that there are 156 possible bilateral relationships that can be built among the participants. And that is also the same amount of questions and same amount of potential bottlenecks. This number will increase exponentially if you consider that each group of stakeholders is made by many actors. And if also consider that there are sometimes trilateral relationships, quadrilateral, multilateral relationships. To put this in context, let's just consider one relationship. The relationship from education to cooperation, for instance. Anyone who knows Africa, but this is also a global challenge, knows that there is a problem linking universities to the corporate world. But the link is important for many reasons. You know, the corporate will provide jobs, internships, training opportunities, but most importantly, the feedback that universities need to maintain their curricula relevant and align with the actual and future needs of the industry. The corporates do invest in research and development, and they need to collaborate with universities. Possibilities are endless, but pick any university that you know. You will find that very few have taken out the role that Stanford, for instance, has played in the US, in Silicon Valley, or Harvard and MIT have played in establishing a vibrant biotech innovation ecosystem in Boston. I'm sure there are many similar examples in the UK. But the good news is a lot of change is happening. Next. I'd like to talk about one good news in Rwanda. which is the Kigali Innovation City project. So the Kigali Innovation City will be a new physical city, a smart and green city, where the government is facilitating the logical and physical connection of the ecosystem participants to remove much of the friction that usually happens when these participants are scattered. So the government is playing a very important coordination role, but at the center of the Kigali Innovation City, there are universities, Carnegie Mellon University, African Leadership University, the University of Rwanda, the African Institute of Mathematics, and progressively, those educational institutions will take over the leadership and coordination of the innovation ecosystem. On the side, the government launched a Rwanda Innovation Fund to provide access to agile capital and expertise, and so on and so forth. So I want just to highlight that this is just a case in Rwanda. I know Kenya has Konza Technopolis City. I was watching the news in Guinea, another innovation city is being launched. So I think there is a constellation of innovation hubs on the continent that is taking place that is set to remedy the failure of coordination that we have seen in the past, hampering the development of innovation on the continent. Next.
Just if I could say, it's almost 11:50, so perhaps we could leave 5 minutes for questions.
Are we 5 minutes before end of the time?
10 minutes before the end.
Okay, let me run just this through quickly and I close. So I was going to talk about this. So ecosystem leadership can also be done by private companies. So this is an example of Absolutis, a company that is trying to remedy the failure. Next, trying to connect the ecosystem players using technology. Next. So this is about building ventures online. Next. It's about building innovation on the cloud. While the innovation cities try to put actors in one physical place, this company is taking the lead to connect the players and the resources online. Next. So there is the investment challenge. The good news is investment into the tech ecosystem in Africa and eHealth is increasing, but the bad news is we are still very far when compared to the rest of the world. Next. So the promote challenge is about how do you drive adoption, use, how does the government take the lead in demonstrating, and how we need to think about preventing unintended consequences. So there is a book suggestion here called The Prosperity Paradox. Please pick it and read about some of these questions. Next. So the regulation challenge. Regulation is important to foster competition. Regulation needs to be flexible to adapt to the fast-changing technologies, protect consumers, and defend national interests. This is very important and often forgotten. So I have included another book suggestion called The Cost of Connection, how data is colonizing human life, but also how data colonialism is also taking place and threatening the continent of Africa. Next. So this is about trust. Another T, so trust, I wanted to share the experience of an organization called Future State that I'm part of that promotes a data sharing based on trust, participation, agency, and choice. So this is a framework, but you can find more information on futurestate.org. Next. So this is the final. I learned one thing a few years ago that I'd like to share. Somebody told me that when you are on the podium and you have the microphone, you shouldn't leave it without selling something. So let me sell something, at least communicate something that I'm part of. So my 9 to 5 job is managing director of the Commons Project in Africa next. And we are also about building trust. One of the things that we do next is now the famous digital health passport. We believe that digital is going to be critical in allowing countries to safely reopen borders during the COVID time. People will need a safe way and privacy preserving way of demonstrating that they have either taken a negative COVID test or a COVID vaccine. So we have partnered with the World Economic Forum to really remedy the trust deficit, to bring everybody together. And the common project is a not-for-profit. So we believe that we will be embraced by the private sector, government, and we will be able to build consensus on the kind of standard that the world needs to adopt in this space. Next. So this is the final, and it's my favorite. It's called QUIT. It's important that the government realize that at some point, it's important for them to step back and not crowd out the space and leave the private sector to play the lead role. And I also recommend a book called Seeing Like a State to show that too much government control sometimes can result into unintended consequences and failure. So I'm talking to policymakers. We can tend to believe that everything will be fixed by policy, but let's also leave time to the market to fix some of the issues. Next. I've asked around, so this is what I learned from WHO, the regional office. Next. So they say priorities are governance, funding. This is what people said on Twitter. They say the biggest challenge is financing and investment. Next. This is what LinkedIn said, connectivity came on top. But I was happy to see that leadership and regulation came as a second concern. This perhaps reflects also difference in composition of the crowds that are on either platform, as we have also seen that amongst the audience here, many said that infrastructure was the top concern and leadership. Next. So a parting shot from me, and then you can also share what you think. Number one, the challenges are interconnected. When you push one challenge, the other also moves. So you need to put your system thinking hat on. Number two, e-health challenges are not unique to Africa. They are everywhere. Number three, COVID has accelerated transformation, but the risk to drive Africa into the cyberpunk scenario is ever present. Number four, Africa is not a country, but experiences and lessons can be shared and universally relevant. And then finally, the opportunity to leapfrog is closing fast. So we need to act with a sense of urgency. Next. So this is the quote I'd like to leave you with by the president of Rwanda. After all, universal health coverage is an opportunity, really emphasizing that all these problems we just talked about are opportunities to do better, not a burden in any respect. And finally, next, I thank you. Thanks again, Dr. Cresson, and thank you to so many people who helped during the preparation phase of this lecture. In particular, I'd like to thank some of the friends who are online. My friend Olasupo, who's the president of the African Alliance for Health, Digital Health Networks, and who was also a student in the University of Birmingham. Thank you so much, and back to you.
Thank you very much. Thank you for this. I really appreciate it. It was such a wonderful, almost bird's eye view of all the challenges and potentials of eHealth in Africa. You have covered so much that, in a sense, I would like to question and for you to go in depth on everything, but we haven't got much time. I hope you can stay a couple of minutes more. Looking at the chat, we have two themes. Few people have asked about, for you to elaborate on your comment that for Babel the data is so important and data is gold. And the question would be, how can African government be supported in taking opportunity of this data goal? More specifically, someone asked that on regulator, interested on how GOI is attempting to harvest the data gold being created by Babel and other such companies. So I think how it is being harvested, but also how the African governments can take advantage of it. I know this is a big issue in the UK as well, and a concern that the National Health Service is giving away the data to some, and there are issues of privacy, but also of intellectual right and of who profits from it. So that's one stream. The second stream of questions I can see is, it's about, Shireen asked here, what is happening in Africa related to community engagement initiatives for building health systems resilience on the ground through village health communities? So that's a question of sort of what are the bottom-up policy to build the health system resilience. And somewhat related to it, there is a question from Eiffel Hogarty, on in relation to common trust solutions, how to drive adoptions of something like this when the European Union couldn't even join together for a COVID tracing app. So I think those two are related. I will stop here. There are more messages, but I think those two issues are quite big. So if you can address them a little bit. If anyone,
thank you.
If I understand, we're running out of time, but if you can stay, it would be good.
I'm happy to stay another 15 minutes, and apologies for getting excited and not realizing that the time was ticking so fast. And I suggest to continue the conversation on social media. You can follow me on Twitter and LinkedIn, and we can continue this discussion. So on the first one, data as gold, the new gold, I think the most important thing is to make sure that the interest of the people are put first. While the question was about how do governments most effectively harness the data that is collected, I think the right question is how do individuals benefit? Because the problem is we've seen too often that the data mining, the data collection and processing profits to corporations. So to shift that power balance, there has to be regulation is definitely, fixing the rules of the game is important. Transparency is important. Accountability is important. So government shouldn't leave private companies to handle people's data without an oversight. And here Africa has the opportunity to learn from the mistakes that other places have already made. US, for instance, where they are now retroactively thinking about regulation now. I think we are in a place where a regulatory framework can be put in place not to block or to hamper innovation, but to make sure that the benefits go to the users, to the consumers, and that the consumers are empowered with, agency and choice, for example. On the question about the community health workers, what are the bottom-up policies to ensure health systems resilience across the continent? First of all, I'd like to say I'm not a public health expert. This is not something that I didn't say before. My background is in technology policy, is in tech software. I wouldn't be fair trying to answer this question, but I know that there is a lot of effort that is being put in place by different governments. especially the government of Rwanda that I have the closest experience with, really increasing the coverage, increasing the number of community health workers, reskilling them, and leveraging their services to sort of lessen the burden on the few health centers and hospitals that we have by treating providing interventions before they get referred, and most importantly, by extending preventive services to the communities. So common trust, how is this going to work when the EU hasn't even agreed on a testing and vaccine approach? I would say that it's a tough problem, and EU has been one of our most difficult markets. We are making faster progress in the US, faster progress in Asia, in Africa. But I would say that one way we've gone about it is, first of all, partnership. So the partnership with the World Economic Forum and other partners has helped a lot. The second way is actually to partner with the private sector, especially the airline industry, because the industry is suffering, is dying. They are at the receiving end of this crisis. So they are lobbying and they are asked. So they join us in presenting this as an opportunity to government as opposed to being a risk. I know there is a lot of discussion about this being another opportunity to create more exclusion. But I would say anybody who travels internationally is used to carry this yellow book. If you go into a country, you've traveled into a country that has yellow fever as a pandemic, you need to be vaccinated against it. I have never heard anybody saying this is privacy invading. So why is it that when you take information that is transmitted on paper, you put it in digital format, people will start raising concerns? I would say that paper violates privacy more than digital, but I stand to be corrected. You're muted, Ella.
Yes, thank you very much for this. I'm just scrolling through if there is more information. If any questions, if anyone wants to ask a question, you can put your hand up and just go and ask it. I had a question because I was really interested in what you were saying at the end about the innovation. And I wonder, you have mentioned many different projects. In terms of policies and regulations, what do you think were the most effective policies in African context to facilitate that innovation, entrepreneurial spirit in relation to eHealth? How the eHealth entrepreneurs be supported through regulations and policies?
The first thing that I would say here is the promotion by the government. When government leads in creating the demand for eHealth innovation, the rest tends to follow quite quickly. So an example current today is in the case of COVID, for instance, Rwanda has started using robots in screening people for temperature, in providing guidance, making hygiene and social distancing measures observed. I would say that the leadership of the government will I can predict that in a few months and years to come, you start to see robotics companies coming in that space and being adopted even by private clinics, just because the government has taken the lead in the adoption and promotion of the use of technology. So beyond the technology regulation, I think the promotion, the adoption, the leading by example by the public sector, it's something that I have seen many countries using to promote success of eHealth.
Thank you very much. Are there any other questions? We had some questions in the chat box, more questions.
I can see Adele. Adele is raising his hand.
Yes, please, if you allow me. What's the best country which has the eHealth already regulated to have a reference for it?
I will give that. I will give this question to the professor.
Sorry, so
the country with the best eHealth regulation in Africa.
Oh no, I'm not sure.
Not necessarily in Africa, possibly worldwide, because I need to go back to my team and see how it goes on the regulations in particular.
Yes, my focus is on the UK, and a lot of countries see the UK as quite forward-looking, and that the regulations are there. Yet, it still struggles. It's a catch-up. So, for example, in terms of privacy laws, we've got European laws. We've got laws in the UK, and that's but it's still evolving. Now, the challenging area is artificial intelligence. So for that, the regulations are still being developed. So the same with standards for sharing information, technological standards, semiotic standards, semantic standards. So even though I would say in the UK, the regulations, the framework for developing eHealth is there, there are still pockets of challenges which are which tax the UK policymakers. And I think it's the case in every single country. Every country starts from different perspective, what's already there, different health system, different government, different economic system. So I think there is no one overall regulation which fits in everywhere. So I'm not sure about in terms of Africa. I think Africa has been quite and Rwanda very, I would say, very forward-looking in that case. So perhaps we can take it a bit further later on an exchange of what are the particular differences in the way regulations are implemented in those two different countries. But it's very hard for me to compare and say which country's got the best regulations. I haven't studied all of them.
Thank you very much.
The other thing is, Adel, I think this difficult question simply because it's difficult to compare the regulations themselves and say this is better than this because the contexts are so different. The challenges that countries are meeting are different. I would say perhaps one way to look at it is to see the country that is performing the best on eHealth, but that may also not reflect the regulatory aspect. It could be another aspect like skills or investment. So it's really complex and difficult to definitely say this country has the best regulation. And I would say if we want to pick and compare two examples, perhaps an African and European example, pick Rwanda and contrast it with Estonia, for instance, because they are comparable in size, of course not comparable in income, but I think that the fact that both countries are pushing digitalization at a very high speed and looking specifically in eHealth, what people in Estonia are allowed to do that in Rwanda they are not allowed to do with their personal health records, for instance, or access, or vice versa, I think you can find an interesting comparison there. I see a hand by Ifa.
I just wanted to add that I think you cannot divorce eHealth from an overall e-government program. Right. This is part of a citizen-centric thing. So if you're trying to move ahead, as perhaps Adele is in the eHealth area, and your government doesn't have policies, regulations for citizen-centric government overall, then you're going to be in problems. And I think obviously Estonia is a front runner. I would say for eHealth, also without a national ID card, you may run into more difficulties than you might have otherwise. And finally, it's also whether healthcare is universal for citizens or only for nationals. These are things that might come into play. But just to say that eHealth is part of e-government and citizen centricity in general.
Yeah, and I'd like to ask people to turn into the chat. There are many, many good ideas coming up there. I see Shirin Madden from who says South Africa has a good health regulatory framework. So Adele, you may want also to look to South Africa. So there are questions about cybersecurity. I could see, I wish we had more time to discuss about that, but I hope that we can continue this conversation really offline as possible. Let me type my social media handles here. So my Twitter handle is this one. And same as LinkedIn. So if you type on LinkedIn, you will find me there.
Thank you very much. As you said, we had other questions. Some questions were very specific and perhaps more relevant to where we were talking, at what point we were in your presentation. But I think we answered, or you answered, and the other contributors, all the main questions. So let's follow it up. Aurora will write a blog based on this, and I hope we can continue the conversation. So once more, my warmest thanks for coming here and for being part of this conversation, and to you, Jean-Philbert Nsengimana, for presenting, for bringing this exciting presentation to us. And we hope to meet again soon. Thank you very much.